Hi, this is Brian Kim. I want to share with you case number 83 in the Best Way to Do Cataract Surgery series. This is a patient with a big pupil and also a soft lens. And so you're going to see double chop, cross chop, an efficient and easy lens disassembly. Some people struggle with the soft lens because when you groove and sculpt, the lens kind of falls apart. It's hard to crack. And then if you try to lollipop the lens with horizontal or vertical chop, the lens can just kind of fall apart on you. And so I feel like this is really the easiest and most efficient way to disassemble the soft lens. And so you can see I use a corneal marker to help me center and size my rhexis. I'm making my paracentesis incisions first on the right side and then the left side. And I want to make sure the incision is flat to the iris plane, which creates a nice horizontal shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then injecting some dispersive viscoelastic to fill the chamber, as well as coat the corneal endothelium. I'm using the cannula to control the eye. For the triplanar corneal incision, I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turning the eye away from me as I do this, and then turning the eye towards me and then entering. And this is the triplanar corneal incision. I inject some more dispersive viscoelastic before I come out in order to prepare for my capsulorhexis. This is a puncture style rhexis. I'm going to puncture with the forceps, pull towards me to create a tear with the teeth closed. I'm trying to manipulate the tear, grasping the right side of the tear to create a little bit of a flap. Once I've created the flap, I go around circumferentially, making sure I follow the corneal mark that I made previously, which will help me to achieve a well-centered and sized rhexis. Once I'm done, I finish the rhexis and burp viscoelastic out of the anterior chamber. And this is the Capsulorhexis hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally, point the tip down, get a nice fluid wave, decompress on the left side, rotating the tip to the right side, and the lens begins to spin. Remove that bubble. Irrigate the surface of the cornea, making sure my sleeve is of the appropriate length. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally. Bringing both instruments together and the lens is divided. This is double chop, placing the chopper around the right heminucleus, pulling it centrally, and dividing the right heminucleus. That is cross chop. Lifting the first quadrant with vacuum, and then emulsifying the lens piece. You can see how efficiently I was able to divide the lens into 3 pieces within seconds. Again, all with mechanical forces, and you're essentially creating a cutting force with the 2 instruments, which works very, very, very efficiently in the soft lens, just like this. Rotating the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, dividing it, and then emulsifying the lens pieces. Basically, when you're cutting the lens piece, this is like really creating a cheese wire to cut soft cheese. You're using mechanical forces to cut the lens piece with the phaco tip and the chopper. Once the endonucleus is removed, I'm removing the epinuclear material from anterior to posterior, and this causes it to tumble out quite easily here. So I take the chopper out, Push BSS in, take the phaco tip out, and I go in with the INA handpiece. I point the tip down subincisionally, removing the cortical material from anterior to posterior, go back subincisionally, doing the same maneuver. When I grasp it and get occlusion, I'm actually trying to peel with mechanical forces by pulling it away from the capsular bag. I switch to polish mode, polishing underneath the rhexis edge. There's some fine lens material on the posterior capsule here, and the polymer tip is just really great for these situations. I can confidently polish the fine cortical lens material off the bag. So with the BSS cannula, I'm going to place it underneath the rhexis edge subincisionally and start to pulse. In this case, the bag is nice and clean. I'm filling the bag with cohesive viscoelastic now. And then I use the sweep to polish underneath the rhexis edge. First on the left side. And then on the right side. Placing the single piece acrylic intraocular lens into the capsular bag. The leading edge goes into the bag. And while the lens unfolds, I quickly transition to the INA. I go in with irrigation off, activate irrigation, and then start to tease off the haptics off the optic. Go underneath the optic, tilting it and rotating it 90 degrees, removing the viscoelastic from within the bag and underneath the lens. By rotating it this way, I ensure that both haptics are in the bag. Switching to polish mode, polishing under the rhexis edge of any potential lens material. Using the polymer tip to rotate the haptics in a horizontal direction. Going under the lens, polishing a little bit more. Switching to visco mode, removing all the viscoelastic from the anterior chamber. I switch to polish mode because I see some fine lens material adherent to the posterior capsule. And then I switch to the visco mode again, and then I'll hydrate my incisions. Some people struggle with the soft lens. It's difficult to sculpt these lenses. If you try to crack within the trench, the lens just kind of falls apart. If you try to lollipop the lens and use high vacuum, again, the lens falls apart. The soft lens is really not amenable to those techniques. And so I feel like the mechanical fracturing technique is really ideal for the soft lens because you're mechanically using the instruments to literally cheese wire to cut the soft lens. And because it's all with mechanical forces, you have exquisite control. You don't have to worry about the lens falling apart and not being able to grasp the lens. Trying to go after it with high vacuum is not a good idea. And so instead of going after it with high vacuum or phaco, which can inadvertently damage the posterior capsule or cause a complication, Mechanical forces is really the most efficient way, in my opinion, to tackle the soft lens. So I hope this was helpful to you, and I thank you for your attention.